I'd like to welcome everyone for joining us for part one of our webinar series, Prostate Cancer Side Effects and How to Manage Them, Managing Erectile Dysfunction and Urinary Incontinence. This webinar series is brought to you by Zero Prostate Cancer and sponsored by our friends at Boston Scientific. So thank you to the Boston Scientific team. Like I said, my name is Shelby Monier. I'm the Vice President of Patient Programs and Education here at Zero. And I'm honored to be your moderator tonight and joined by Dr. McIntyre. So just a couple of notes right before we get started. And again, I'll buzz through these. Our webinar is being recorded and it will be posted on our website tomorrow, zerocancer.org. Be sure to check that out. As soon as the webinar ends, we will send you a survey. Please, please, please take a look at that survey. Give us feedback on both the event, not the technical difficulties part, but the content, the event, any topics for the future. We use those to help build Zero's programming to help meet your needs. So really give us that information and that feedback. During this webinar, you can submit questions. We will get to as many as we can at the end. I'd like to, again, thank our sponsor, Boston Scientific. This is part one of a two-part series. Part two will actually be held on October 9th at 4 o'clock Eastern. That registration has actually already happened. So most of you are registered for both. If you're not, go ahead and register. We will get that registration link in the chat for you. We will also send out our continuous emails to make sure that people are aware of part two. So just a bit about Zero. If you're new to the organization, Zero is the leading national nonprofit with the mission to end prostate cancer and help all who are impacted. Zero advances research, provides support, and creates solutions to achieve health equity to meet the most critical needs of our community. Thanks for the slide work back there. I appreciate it. So we are proud to offer a variety of patient support programs and educational tools, all of which are, of course, at no cost to patients and their loved ones. So please spread the word if you know someone, if you yourself are in need of some extra support or contact with supportive information and resources. Please know that you're not alone. Your loved ones are not alone. Zero is here to help. Just quickly, 0360 is our individualized case management program. This pairs patients with a trained case manager and kind of walks them through navigating insurance, maybe signing up for supplemental insurance, fighting if something was denied and should not have been, helping get connected with emotional support, transportation assistance, financial assistance programs. We also offer some additional peer-to-peer support programs, one through a mentor program, which kind of pairs one-on-one individuals together based on the needs of that person who's requesting a mentor. And then we also have support groups. We have about 165 active support groups, both virtually and in person, meeting all over the country, and a few outside the United States. So we also have groups for unique community members who might have special needs and different unique challenges that they are dealing with. We have some virtual support options online. So Zero Connect is our private Facebook page. And then we also have a really active online forum through a community on Inspire, where we have nearly 30,000 community members. So really just know that you are not alone. If you have questions, if you have comments, or if you have concerns, you can go to these communities and to the Zero community and get support and get answers to your questions. So with that, please join me in welcoming Dr. Matthew McIntyre, a board-certified urologist and provider at Urology Associates. Dr. McIntyre offers quality, dedicated care to the community of Mobile, Alabama at the Providence Hospital and Mobile Infirmary locations and specializes in treating male infertility. So with that, Dr. McIntyre, I will now pass it along to you. I hope you can kind of grab that virtual remote so you can advance through your own slides, and I will zip it. Pleasure having you here with us at the Zero webinar tonight.
Thank you, Shelby. I appreciate your time. Sorry again for the technical delays, but I think we've surmounted it. So tonight we're going to be talking really about the effects of prostate cancer, which is something I spend a good bit of my practice on. And just briefly, I'll say my background, I did my general urology training in Charleston, South Carolina, and I realized that I had more of an interest in what I'll describe as the functional aspects of urology and andrology in particular, which is really all the maleness aspects of urology. So it's erectile dysfunction, testosterone replacement, post prostatectomy incontinence, and post prostatectomy erection difficulties as well. So with my interest in that, I did do a fellowship where I worked with Dr. Larry Lipschultz in Baylor, Texas, at Baylor in Houston, Texas, excuse me, for a year, specializing in doing exactly this. And fortunately, I've been able to do this for the last 11 years here in Mobile, and have a busy practice where unfortunately I encounter men who have these issues on a daily basis. So we'll jump into it here. As far as I do not have control, I'm not sure if you can help me, moderator. I cannot advance the slides. Oh, the internet's got us again here, huh? There we go. So we are on to the next one. So ed.cure is a good website if you have other things that you want to look at here, specifically looking at erectile dysfunction. It's got just some good general information, some patient testimonials that if you had interest, you could take a look at as well. So let's talk a little bit more about erectile dysfunction. Basically, what is erectile dysfunction? And the million-dollar question, and the thing that I ask all my patients essentially is, are you able to achieve an erection that's adequate for intercourse? And the answer to that is going to be binary. It's going to be yes, or it's going to be no. And if the answer is no, then we need to do something about that. The good news is there's several things that we can do about it. We're going to talk a good bit more about that, throughout our talk here. But in brief, I will say this is a very common condition. 1 in 5 men age 20 or older suffers from erectile dysfunction. When you hit 40, it's about half of men in that age range have issues with erection. So you are not alone is really the thing that I try to tell most patients with this. This is something we deal with on a routine basis. I'm still not advancing here. I'm not sure what we're going to do.
Dr. McIntyre, I'll just take control back and advance.
I apologize. Like I say, unfortunately, my button pushing isn't adequate for the for the advancing of the slides. But I apologize about that. So we talked a little bit about how we define erectile dysfunction, but really I want to talk just a minute about what erections are, because it's actually a very dynamic process that we talk about. And it really starts through a number of systems that are incorporated to generate what we consider an erection. Of course, it starts with what is psychogenic, stimulation, whatever it is that excites you, that makes you think sexual thoughts, sends a signal from your brain down to your penis, and in particular, the blood vessels that supply the penis. Actually, what an erection is when blood flows faster into the penis than it can flow out. So just like any hydraulic process, when you're putting pressure in there, such as a hose like you see for a fireman, when the firemen are done, they roll up the hose. It's just a flat thing. But when they're using it, it's a 4-inch round tube that you can stand on or run over. Now, obviously, I wouldn't advise you to stand on or run over your penis, but it's the same process as far as you're using this hydrodynamic pumping of fluid from the heart to the penis, which causes the firm, rigid erection. It's not just the blood flow, though. The actual portions of the penis itself that are muscular relax. And as they relax, they fill with blood. And it really does look, if you slice into a penis, it looks like a sponge. And that sponge can change from big openings to small openings. And when it changes to the big openings is when it allows us to have an erection. As I say, it's when blood flows faster in than can flow out. The other portion of this process is actually the veins around the outside of the penis get constricted because they get smashed by this tissue that's expanding and don't let the blood escape the penis. And that's what helps to maintain an erection throughout intercourse. It takes all of these pieces put together for us to really get to what we consider a usable erection. And things can go wrong in a multiple effect for all of these portions of it that can cause erectile dysfunction. Next slide. When we talk about causes of erections, there's several things that can cause problems. The biggest thing, far and away, is vasculature. And I said it starts with the signal from the brain to the arteries of the penis. Anything that disrupts that is bad for erections. And we'll talk more specifically kind of about vascular and cardiovascular disease coming up. But the main thing is there are a number of issues that can really cause us problems. Smoking is a problem, diabetes is a problem, hypertension, dyslipidemia, or the increased lipids are a concern. Depression and obesity are all described slantwise because they give us issues, that can impact these systems that we've already talked about. And of course, the other thing that I would point out, on this slide is that erections are not just a medical issue. It's also a relationship and psychological issue. We can pull up the next slide. We can take a look at that. I mean, I think all of us can think of reasons why we would want to continue to have erections. And if you can't, it's a problem for many, many men. Next slide. So this poor couple seems to make it throughout our entire presentation. I'm not quite sure why I use the same picture, but he's got all these problems. The first problem we're going to talk about is diabetes and erections. So, of course, diabetes it's an endocrine disorder, actually. So it's a hormone problem. And the hormone we're talking about specifically is insulin and the ill effects of your body's inability to produce or use insulin, which is how we control the sugar that floats around in our body all the time that we eat. Patients with diabetes are less responsive to oral treatments as a result of the effects of too much glucose in the body and its ill effects on, in particular, the nerves and the vascular systems. And in some patients, erectile dysfunction is the presenting symptom for diabetes. That's rare, but I will say my youngest patients that I treat for erectile dysfunction are overwhelmingly affected with diabetes, in particular type 1 diabetes. Of course, that's a condition that has onset during childhood years, but is a problem for a lifetime of issues. Next slide. The issue we really have with diabetes and what it does, it has a number of effects on the body. It damages the nerves, which is the cartoon that we're seeing here. The nerves have what's called a myelin sheath, which is really fat that surrounds the nerves. That is the conducting system so that the signal can move along the nerves quickly. Well, the sugars that are elevated in diabetes attack this fat coating and destroy it, so the signal can't transmit. It's almost like taking a telephone cord and cutting the line. You'll never get a phone call. Same idea here. The signal from the brain to the penis that we discussed isn't there to be had, and so erections just don't happen. The other thing that they're showing us in this cartoon is that the vasculature, not only to the nerves, but also to the penis in and of itself, is affected and damaged, so that these blood vessels can't dilate like they're supposed to, allowing that blood to flow in and resulting in the mechanisms that really lead to erection. Next slide. Factors that increase ED in men with diabetes: the older you are, the not as good your erections will be. As I've described, how long you've had the diabetes is an issue. In particular, type 1 diabetics are disproportionately affected with this. And if your sugars are way out of whack, that's what's going to harm you more than anything else. And I often warn my patients, that this is it's a disease that is just as dangerous as cancer. Unfortunately, instead of the cancer one-time diagnosis and one-time treatments, it is an every 4 to 6 hour issue because everything they eat, can be affected with that, and is a significant challenge for these patients moving forward. Next slide. we've touched on this a little bit as far as the connection between the vascular system and erections, but this is something really requires its own special attention. And really, the difficulty that results in erectile dysfunction is the same disease process that we see in patients who have coronary artery disease. When the arteries of the heart get affected, we talk about a heart attack. When arteries of the penis get affected, we talk about erectile dysfunction. But the reality is it's the same problem. It's just a different part of the body. Next slide. Here, they're just showing us in a schematic form the size of the blood vessels that supply the organs that we're discussing here. The one all the way on the left, the smallest arteries, are the arteries that actually run down to the penis. And what's interesting about these arteries, of course, is that they're contracted most of the time, because we don't walk around with erections all the time. As we say, it takes whatever stimulation we're going to have. But when they are activated with this stimulation, the blood flow that goes through them increases by 10-fold. So we see this huge increase, or this dynamic change in these blood vessels. So if they harden, just like the arteries of the heart can harden, they can't do their job. And that's really what we're trying to show here, why these arteries might be affected disproportionately compared to the arteries of the heart. Now, I will say, in patients who have this as a solitary factor and have significant family risk factors associated for heart disease, which would be heart attacks or strokes before age 55, I often send those patients for cardiovascular evaluation to my cardiology colleagues, as well as trying to address their erectile dysfunction. Next slide. Reducing risk, I would describe this as a slide that your grandmother could have explained to you. Hopefully your grandmother didn't talk too much about your erections, but at the same time, eating well, exercising, losing weight, not smoking. I mean, I think we all know the things that we need to do to eat healthy. Next slide. Now, this is something that is probably closer to people's interest as far as erectile dysfunction and treatments for prostate cancer. I spend a good bit of my time actually addressing this specific issue in my practice. The real crux of this is that the prostate lives next to the nerves that run down to the penis that we've discussed that carry the signal to these blood vessels. And anything I do for prostate cancer can be bad for these nerves. Like I say, regardless of the treatment we choose, they can be damaged. I always describe this to patients as, unfortunately, there's no free rides with prostate cancer. Any way we choose as far as radiation versus surgery, because of the proximity of these nerves, is going to be an issue. If we can go to the next slide. This is a schematic of really where the prostate lives, and there's no on this the anatomy isn't highlighted as well as I might have liked. You can see that the prostate lives between what is the bladder and the urethra, and what also lives here on either side of the prostate, running down through there. You can see the nerves on the inside. Well, my job when I'm taking out prostate cancer is to carefully peel these nerves off of the prostate and then lift the prostate up, taking the blood supply as I go and literally cutting it out of the body without damaging these nerves. Well, I will tell you, God did not design the prostate as a bolt-on part. Removing the prostate was totally our idea. And as a consequence of that, just touching these nerves damages them. As I say, I've got to carefully rip the prostate out, leaving everything else behind, trying not to damage this. And the reality is there's just no good way to do that. The same issue can result from radiation. So radiation is, of course, where we use X-rays to zap the cancer that lives inside the prostate. What the radiation actually does is it hits the DNA of the prostate and the prostate cancer, and it chops up the DNA, the blueprint, so it can't make more cancer cells. What also damages these bystander cells that we're talking about, these nerves that run down to innervate the penis. So again, a brief anatomy lesson on why this is bad for erections. But essentially, when you remove the prostate, you damage the signal that comes from the brain, so the penis never gets the signal again, or could never get the signal again to initiate the mechanisms we've already talked about that result in erection. Next slide. So in the United States, our mainstays of treatment at this point are radical prostatectomy versus radiation treatments. And as I've already described, either way you go, it can damage your ability to get and maintain an erection adequate for intercourse. The good news is we've got some fixes for this. Next slide. So what are the fixes? Step one is go and seek help. I tell patients all the time that there's almost no one I can't get to having erections again. It's just a matter of how hard we need to work on these erections or how hard you're willing to work on these erections. I've got 5 treatments that we're going to talk about tonight. Almost any of them may work for you, but we may have to escalate therapy till we find the one that does work for you. Step one is to really talk about this, though. So the reality is, I cannot write Viagra fast enough to keep up with the number of primary care doctors out there. And the reality is most ED is actually treated in the primary care setting, and we have good treatments for it in the form of Viagra, Levitra, Cialis, Stendra. All of these are available to us and work pretty well. Anyone who's watched golf in the last 15 years knows that there's at least something out there for treatment of erectile dysfunction. And the vast majority of men, they help a significant amount. Sometimes we need to escalate therapy. And that's where someone like me, a urologist who really specializes in this and can offer additional therapies, comes into play. Next slide. So what are the treatments? I mean, in brief, we'll go over these more in detail, but I've really got 5 things that I really offer to patients. Oral medicines, vacuum device, injectable medicines, and penile implants. Next slide. Of course, we recommend all of the normal things that for a healthy lifestyle that we've already talked about, working on controlling blood pressure, controlling glucose and diabetes, bringing those under good control. But the reality is by the time you get to me and we're talking about it, all of these things have probably already failed, or the disease process has gone beyond what we're going to be able to accomplish just through lifestyle modification. One interesting note, we talk about psychotherapy, the psychogenic ED, or the inability to get an erection based on either anxiety or trauma or some psychological concern, is a relatively rare form of erectile dysfunction. Not impossible, but rare. But it's interesting to talk about that because when the initial studies came out on ED, and in particular when the first real significant textbook on ED, Walsh's or Campbell's Urology, came out, they published that 90% of erectile dysfunction was due to psychogenic causes. So all we had to do was slap people on the back and say, "Get back in there, Tiger. It's going to be okay." We fast forward to today, and it's laughable to look back at because today we know that 90% of erectile dysfunction is secondary to a physiologic issue or problem that we need to treat and address. Next slide. The easiest thing to do at this stage is for treatment of erectile dysfunction is to try one of the pills. And the good news is, as I say, we've got relatively good pills out there. These are the PDE5 inhibitors, which are oral pills that we take. There are really 2 ways to take them. You can either take them as an on-demand, so an hour before you're going to have intercourse, or in the case of Cialis, you could take daily Cialis, 1 pill every day, so that you're always ready to go. And they work pretty well, actually. This was a significant game changer. The first one that came out, of course, was Viagra. It came out in 1998. Interesting story about Viagra. So Viagra was originally developed by Pfizer and intended to be used for hypertension. They were trying to lower blood pressures associated with this, and we're thinking this was a good mechanism to do so. Its actual first indication is in a condition called primary pulmonary hypertension, which is, interestingly, a disease most commonly affecting women. And it's funny, I've had several patients come through and their wives, tell me that they're on Viagra at this point because that was its first indication. It was branded under Rialto, and was taken daily for these individuals to try and help control the blood pressure in the pulmonary arteries. And the original studies that they did for that, they were looking at it for hypertension. And it was interesting, in these studies, men came back after the study was over, asking if they could get more of the medicine because of the unintended consequences of improved erections as a consequence of these. As I say, they work pretty well. What they really do is they help to increase the amount of blood flow going into the penis, increasing the size of these arteries. Blood goes in faster than it can come out, and thereby increasing the erectile function. Most people do fairly well on them. There are some side effects associated with the medicines. The only true contraindication is if you're on nitrates for your heart. If you're on nitrates for your heart, then we cannot give you the PDE5 inhibitors, and because it could potentially lower your blood pressure and give us an issue there. So that's the only downside really of that. Side effects otherwise, a flushing feeling, stuffy nose, kind of a headache are the main things that I hear. For many of them, you need to take them on an empty stomach. So if it's date night, you kind of have to plan around that. You can't go have lasagna and then take the medicines, because it'll bind to the fat in the food, and then you don't absorb it very well. And so you've kind of wasted the medicine in the evening. Next slide. So the next thing we'll talk about is a vacuum erection device. And a vacuum erection device is just what it says. So it is a vacuum pump. It's a tube that you put over the penis, and then you apply a vacuum that then fills the penis with venous blood into these spaces that we talked about, which ordinarily fill with arterial blood. But it pulls the blood in there. Then you put a ring on at the base to hold that blood in to mimic a natural erection. So the good thing about this is that it is a way to mimic a natural erection that can be used for treatment of erectile dysfunction. I will say I have a number of patients in my practice who use this and enjoy it. It's not for everyone. I always describe it as it's kind of, it is a treatment for men who are in a very stable relationship. Because if you think about it, you have to start the action, stop, go do the pumping, come back to the action. So it's a little bit cumbersome is the way I'll put it to you. The good part of it is you buy the pump and you can use it till the wheels fall off, that there's no extra costs, that and it does work on demand. It's not obtrusive. There's no medicines to continue to buy. Downside of it is, like I say, not the most spontaneous way. Interesting story about this. This was actually invented in a bicycle repair shop in Augusta, Georgia, actually. So you can go online and you can Google Augusta Medical, was the original creator of this device. And what they did was the bicycle repair shopman unscrewed the bottom from a bicycle pump, put his penis into the pump, pulled the vacuum up, and created, a vacuum around his penis and said, aha, I've got it. I'm going to cure erectile dysfunction. He did find a cure. Of course, at this time, when he came up with it, there weren't very many cures out there. And again, it does work, and you can still buy devices from Augusta Medical. Next slide. The next thing we'll talk about are intracavernosal injections or injection therapy. Now, this is a good way to get an erection if you've tried the pills, we're not getting where we want to go, and we want to continue to try a medical therapy to get your erection again. Now, the way this works is it is exactly what it sounds like. You take a needle and you inject medicine directly into the side of the penis that causes blood to flow in faster than blood flows out. Now, this is a pharmacologic erection. This is not because you're thinking about sex. Clearly you wouldn't do it without, wanting to engage. But at the same time, the medicine is in there and causes these blood vessels to dilate, whether you're thinking about sex or not. It works by bypassing the system that we've talked about, as far as you don't have to have the neuronal input from head to penis. So if these nerves are damaged during prostate cancer treatment, we're able to bypass that and still get your natural erection again. This is stronger than the pills. So typically, if I'm having someone who is failing therapy with the pills, we'll move on to this as a second-line therapy. And it does work. It works pretty well. Now, of course, I have patients that tell me all the time, well, doc, What, you mean I got to put a needle in my penis? And the answer is yes, but it's a small needle. It's not terrible. If it was terrible, no one would do it. And I literally have hundreds of patients in my practice who use this as a treatment method to gain erectile function again. It's been around for quite some time. It was interesting. This came out actually in the late 80s is when this was really developed. It came about after we noticed in patients who were undergoing vascular surgery, the vascular surgeons would actually give medicines that would dilate blood vessels because that makes it easier to sew on blood vessels in the body. Well, they noticed when they did that patients on the operating table would develop erections. Well, they said, well, gosh, we as urologists need to figure out what's going on. And so we did. So we looked into it and we developed, at this point, we use what's called trimix, which is a mixture of 3 medicines, phentolamine, papaverin, and prostaglandin E1 or alprostadil. That's typically what's in these medicines at this point. They work very well, and most patients who get benefit from this get benefit very quickly from it. Interesting story about this one. So when they were coming up with the best formulations of this, we were talking about it at the American Urological Association, which is where all the urologists get together and also make sex very boring in graphs and pictures and numbers. And there was an investigator named Giles Brindley, and Dr. Brindley is British, was doing his research on this, and he had, fabulous graphs and charts showing everything that occurred after he'd given patients these injections at different intervals. And of course, he says at the end of his talk, says, well, the only confounding factor in all of this is that there's no way to rule out that these are psychogenic erections that, patients were getting on their own. And of course, everyone in the room is saying, well, I guess that's true. Yes. And he says, well, I would wager to say that many of you would guess that giving a lecture is not very, sexually stimulating. And again, everyone kind of looks around and says, well, yes, that's true. And he says, well, I've injected myself before I came down. And at that point, he steps from behind the lectern and drops his pants and shows that he indeed has an erection as a consequence of taking these medicines. And that was one of the first, I'll say, public demonstrations, that these medicines were valuable. Good part about them is they work. Downside of them is you have to give yourself a shot in the penis. If it works too long, so if you give yourself too much medicine, as I've described, it's not because you're thinking about sex, it's because we've done the medicine, then you can end up with something that you have to come in and see me for, and we have to do something in the middle of the night to get it to go down. So that's bad. But most people do fairly well. Next slide. The last thing we'll talk about is a surgical correction for this, and this is the penile implant. And what I'll specifically discuss is the 3-piece penile implant is what I mostly perform at this point. The reason is the most physiologic. With a penile implant, we are able to mimic a natural erection. Now, clearly, this was man's idea, not God's idea. It's the best we can do to mimic what you had to begin with. However, it is a good way for men to get erections who have tried everything else and nothing else is working. Then we'll move on to this surgical correction. I always typically warn patients that this is, kind of the last stop. The reason is that you can't go backwards. So we can't put an implant in and you go, gosh, I'm really interested in those injections again. You can't, of course, do an injection into an implant. It won't work. The way we put the implant in, it actually takes up the space that naturally is filled with blood and gives you your normal erections. As I say, the good part about this is it works. It is a permanent fix from the standpoint. You don't have to keep buying medicines. You don't have to keep giving yourself shots. You're ready to go whenever you want to go. The 3 pieces of the implant, the reason it's called a 3-piece penile implant is because you've got basically special water balloons that live in the penis. There's one on either side of the penis that fill with fluid. And when they fill with fluid, they mimic an erection. You've got the pump that lives in the scrotum. That's how you actually control the device to let it up and down. And then you've got a reservoir that lives inside the belly. It's just like your bladder. You can't see it, you can't feel it, you can't touch it, but it's in there. And that's where the fluid moves back and forth from the penis to the reservoir to store the fluid until it's ready to use. Next slide. There's more than one type of implant. I just briefly mentioned this because not every patient is the best candidate for a three-piece penile implant. In particular, patients who have significant dexterity problems or can't use their hands. Clearly, I can't give you a pump if you can't pump it, and that's the reason we mentioned the malleable prosthesis, which I'll describe as more of a coat hanger method, where it's a firm, malleable, bendable rod that when you're ready to have sex, you bend up. When you're done, you bend it down. And that's pretty much how it works. And again, it is a good way for men who aren't as dexterous with their hands to be able to get an erection that's adequate for intercourse. I mentioned just the three different styles of this. The now latest and greatest is the Tenacio pump. The AMS has gone back and redesigned this to make it a faster pump and a more easy letdown process is the new redesign. Having said that, the MS pump I'll describe as tried and true. I've done, again, hundreds of these, and patient satisfaction rates with these are very, very high. Next slide. Again, this is just in schematic. We've got the three pieces that are highlighted on this one. We've got the pump that lives in the scrotum down near the testicles. You've got the special water balloons which live in the penis that get rigid and flaccid, and then you've got the pump that lives behind the bone right there next to the bladder. We've been doing this for a long time. The track record from this is actually pretty good with this, and the devices themselves are robust. Clearly, these devices are designed for you to be able to have vigorous penetrative intercourse with. So they've got to be tough enough to be able to withstand that. The downside of this, of course, it is an operation to be able to get there. It takes about an hour to do this operation. I make an incision between the penis and the scrotum. I'm able to put everything on the inside between the penis and the scrotum. Afterwards, you wake up and you go home. You have a catheter for about 24 hours and a big dressing on for 24 hours. You'll take those out at home, and I see you back 1 week after the procedure to make sure everything is healing well. We cannot use the device. I say it's like any other broken bone. You have to wait 6 weeks before you're going to be able to use it. Same with this. The risks, any surgery there ever was has potential risks. And anyone who tells you that there's no risks, that it's all good and no bad, is lying to you. The risks associated with this: infection, bleeding, damage to surrounding structures. This is a mechanical device, just like any mechanical device. I always say it's like the water pump on your car. It can go out. If it goes out, it's got to get fixed. Having said that, most of these devices last 10 years or better. I tell patients who are younger, if you're 42 and you get your implant with me, you're going to see me again. We're going to need to do something with this at some point in your future. If you're 72 and you get your implant, most of the time, I challenge you to wear it out. Come back and see me again if this thing wears out. It is, I always say, it's like the tires on your car. The more you drive, the quicker it wears out. Next slide. This is just a little schematic, a little cartoon of how the device itself actually works. So you squeeze the pump, you can see the fluid going through from the reservoir through the pump into the cylinders in the penis. It mimics the erection here. The erection lasts as long as you want it to last until you push the button, and at that point, the erection goes down, the fluid goes back to the reservoir. Next slide. What to expect from the procedure: usually done outpatient. Now, the incision, as I described, I use what's called a penis scrotal approach. There's more than one ways to skin this cat. That's what I prefer, and for reasons that I won't go into tonight, I think it is a good approach. It is done under general anesthesia. I wake up and go home the same day. Cannot use it for 6 weeks afterwards. We get you back and show you how it works. Next slide. Coverage, this is covered. It's covered by Medicare. It's covered by most insurance plans. Coverage is not something that's normally a barrier for me getting patients to the operating room to be able to help them with this if it's something that they're interested in. Next slide. Patient satisfaction. high, is what I'll put it to you. So again, if you take a group of men who cannot get erections any other way, and we give them the ability to engage in satisfactory penetrative intercourse again, you have a pretty happy group of men, is the way I'll put it to you. And most of my patients fall into this. Now, no 100% in medicine. I'll be the first one to tell you about that. But satisfaction rates are well better than 95%, and partner satisfaction rates are also very high. So it's good for her. It's good for him, is the way I'll put it to you. Now, I will say one thing that does need to be mentioned, this is the best approximation of your erection that I can do. And what I mean by that is this is not the erection that God gave you. It's the best approximation of filling that skin with the fluid that we've discussed to really recreate the erection process. If you come into me and you're Big John and we do an implant, you're going to be John. Now, again, you'll be usable, John, but it won't be your 18-year-old erection again. Next slide. We've covered a good bit of this. I won't belabor all of this. I mean, the benefit of the erection, of course, or the benefit of the penile implant, it is a way to get erections, moving forward. Next slide. Risks, I guess this is for all the attorneys who are on the call. As we've described, infection, bleeding, damage to surrounding structures. It is the best approximation of your erection that I can do, but it is not your old penis. Next slide. The main thing I would say, clearly anyone who's on the call is interested in talking more about this, but there are resources out there. There are things that we can do to help individuals who do suffer from erectile dysfunction. And I would encourage each of you, as you see fit, to seek out help. Next slide. More for the lawyers. Next slide. Next slide. Stress incontinence. Now, clearly we're winding down, but I'd like to at least mention this. So stress incontinence is the involuntary leakage of urine, in particular with coughing, laughing, and sneezing. Very common after men undergo radical prostatectomy, and it's the #1 real cause for that medical condition. Now, the basis of this slide is that there are a lot of men out there who have this problem and could benefit from some treatment. We include this just to say that you are not alone, you are not unusual, and I would encourage you to seek out help if you so desire. Next slide. Urinary process, again, everyone probably understands at least the basics of this. The bladder stores urine. The prostate sits between the bladder and the urethra. The urethra is the tube that runs out to the toilet, and the prostate has a valve-type effect. When I take the prostate out, I damage that valve. Well, there are ways to try and help recreate that valve, and I'll briefly go over those at this point. Next slide. Next slide. We won't cover too much of that because we're running short of time. Again, I think the point of this is the quality of life question. All of us on the call can probably think of reasons we don't want to be soaking wet with urine all the time. So I won't belabor that too much. Next slide. So again, we talked briefly about this, stress urinary incontinence after prostate cancer treatment, very common. I spend a good bit of my time treating men who have this condition. Next slide. Again, here is our schematic of looking at treatments for prostate cancer. We remove the prostate. As I say, the prostate has a valve type effect. When we remove that, the valve gets stuck open. So it's just like leaving the faucet open on the side of your house, water comes running out. Same idea, except the water's running out of the bladder. Next slide. So what do we do about this? I mean, that's kind of the whole point of this. I'm sure other than the urologist in the group, not many other people have that much interest in really talking about the physiology and problems about it. But the things that we can do about it, behavioral changes. So that's drinking less fluid, what's called defensive voiding, where if you know where every bathroom is, because you're using every bathroom between, church and your house, Walmart and your house, your activities, you're trying to avoid this by having an empty bladder because you can't leak from an empty bladder. The next thing we talk about is pelvic floor therapy, which can help with restoring continence after prostatectomy. It is an answer. It is not the ultimate answer. And then, of course, dealing with it means pads, diapers, catheters, some ways to either try and stop externally or catch externally the leakage that's occurring. Next slide. Benefits of treatment, we'll say less leakage. I can never promise you to be exactly like you were, but I can significantly improve your symptoms. If I can take you from 10 pads a day where you're miserable to 1 pad a day for a few drips, most of those guys are really, really happy at the end of this. The first thing as far as our treatments from this would be what's called a male sling. Next slide. Now, a male sling is actually a small, it's plastic that goes under the urethra to help pull the urethra back up towards the bladder to help recreate that valve type effect that we discussed. The benefit of the sling is that there are no moving parts, and it works all the time. Morning, noon, and night, it's always on. You're not thinking about it. You don't have to do anything. It's there and helping to protect you from the leakage issues. The downside of the sling is it's not for everyone. And I cannot, again, promise you 100% dry. It is for men with mild to moderate incontinence. So if you're using 10 pads a day, that you're just, when you stand up, you leak, you don't do anything, you leak, this is not for you. If you have 1 to 2 pads per day, then this may be an issue, maybe a potential solution for that to really slow you down to either using no pads at all, or maybe just 1 for a few drips occasionally. Next slide. The next thing we'll talk about is what's called an artificial urinary sphincter. Let's go to the next slide. I think the picture will be worth 1,000 words. So this is how it works. It's very similar in process to the penile implant from the standpoint it's got a pump that lives in the scrotum. This time, instead of the water balloon that lives in the penis, it's a water balloon that lives around the urethra. And that water balloon blows up and shuts off the urine flow, so that recreates the valve effect and stays closed until you want to pump the pump in the scrotum. Then it opens it up, urine comes tumbling out. That's essentially how it works. The surgery is a little different. It is outpatient surgery. Risks are the same as far as infection, bleeding, damage to surrounding structures. Again, anyone I offer this to, I do give the caveat that I cannot get you 100% dry, but I do think that I can significantly improve your leakage, or I wouldn't be offering it to you. Next slide. This is in brief how the device works. Very similar in function as far as there is the pump that lives in the scrotum. This time it's activating the sphincter, which you can see around this pink urethra. When you pump it, it opens up, the urine comes flowing out, and then it defaults, it closes back off until you're ready to urinate again. Next slide. Outpatient surgery, typically 2 incisions. Again, same 4 to 6 week supply as far as can't use it until it heals up. Next slide. Patient satisfaction, good. I will say they're not quite as good as the effects from restoring erectile function, but well worth it for men who have a significant problem with urinary incontinence. Next slide. Again, coverage is not normally an issue with these. These are covered by insurance, including Medicare. Next slide. Next slide. What I'd like to do at this point, I know we kind of rushed because of all of the technical concerns, but I would like to get to at least 1 or 2 questions to see if there's any specific things that the guys wanted to hit on. Just a moment or 2 more.
Thank you so much for that. We do have a couple of questions, and we should be able to get at least to a few. So the first question we had was regarding erectile dysfunction, which isn't surprising. That's probably the more hot of the 2 topics. But this individual has had trouble with getting and maintaining an erection for more than 12 years following a radical prostatectomy. And so is obviously struggling with that and is wondering specifically about Trimix and how it will work, and if it's worth trying after so many years.
So the way I use trimix in my practice, clearly they've probably done a couple of things. My guess is that they've had just oral medicines. It's an escalation of therapies. I'll typically try monotherapy medicine, then I'll try a dual therapy medicine like a daily Cialis plus an on-demand Viagra. If we fail that, I'll move on to trimix. Trimix comes in several strengths. I'll describe it as more concentrated Kool-Aid. And typically we'll get the patient to come into the office. We'll try several times in the office to make sure that we're getting an adequate response here. If we get an adequate response in the office, then they'll go home with a prescription for this where they can then, do this therapy at home. If we can't get to that, we'll continue to escalate beyond that to talk about vacuums or surgery. But I guess, 12 years is a long time, to not escalate therapy. If we've been trying something and we're not getting where we want to go, it's time to move on to something else.
Great, thank you. The next question, this individual is wondering if they've tried injections of liquid solution of Viagra instead of the 3-part mix that you mentioned earlier.
There's no real good data that is superior. In fact, I would probably say it's not, because of the mechanism of action that it uses. It's probably not as good as the injectable trimix medications.
Okay, great. And we're getting a few more in, so I'm just going to run us up until right at the top of the hour. We have an individual who has, let's see, sorry, I'm trying to kind of read and speak. Has explained that his penis is only about 1.5 inches long, and so is wondering if an implant can actually extend length, or if you how that works.
What I would describe and what I show patients in the office is what's called stretched penile length. Now, stretched penile length is if you grab the head of the penis and pull directly away from the body at a 90-degree angle. That is, the filling up the skin that God gave you, is the way I'll describe it to you. Now, a penile implant will not make that any longer, but it will fill up the skin that's there. But that's what you could expect, from that. I get questions relatively frequently as far as about size and things like that. I will say